This week on Inside Olympia, how could federal cuts to Medicaid affect Washington's health benefit exchange where people go to get health insurance? And what is the status of Washington's first in the nation long-term care benefit program? On the program, Ingrid Ulrey, the exchange's CEO, and Ben Veghte, director of the WA Cares program.
From the TVW studio, it's Inside Olympia with host Austin Jenkins.
Welcome to Inside Olympia. Washington was the first state to establish a mandatory payroll deduction to fund a long-term care benefit. What is the status of that program, especially after surviving a rollback measure on last November's ballot? In our second half, we will get an update from the program's director. But first, Washington is a leader in affordable health care offerings through expanded Medicaid, even for undocumented immigrants, and subsidized individual plans. But proposed federal cuts to Medicaid, restrictions on immigrant care, and potential big premium hikes in the individual market could force the state to cut back on offerings and raise prices. What is the state preparing for? Joining me now is Ingrid Ulrey, CEO of Washington's Health Benefit Exchange. Good to see you. Thanks for being back.
Thank you, Austin.
I think it's always good to just, for table-setting purposes, remind people of what the Health Benefit Exchange is, how it connects to Medicaid, and also the individual insurance market.
Absolutely. So the Health Benefit Exchange is our state-based marketplace for health insurance coverage. We serve people in two ways. Our platform, called Health Plan Finder, is the front door for people to come in, shop, compare, and purchase a plan on the individual market. And it's the only place where they can qualify for both federal and state premium assistance. At the same time, we also enroll people in the state's Medicaid program, Washington Apple Health. So we have many families or mixed families, and one member is eligible for Medicaid, which we call Washington Apple Health, and another needs to purchase a private plan, and we can serve everyone, and we do it in real time. So we check federal data resources, trusted federal resources, sources automatically in our system. And it can be complex, but we have a lot of help through our call center, as well as in-person assisters around the state who help individuals and families get coverage either through private subsidized health insurance or through the Medicaid program.
And just so we can picture this a little bit better, people are coming through the front door at the exchange. What percentage or how many are ending up on Medicaid versus in the individualized market?
Sure. So we approximately just under 300,000 folks are on the the exchange side. They purchase what's called a qualified health plan, and then folks who are lower income who qualify for Medicaid we enroll in Washington Apple Health, and that population is about 1.7 million.
So most of the people are on Medicaid, a smaller percentage
Absolutely.
On the individual market.
Yes.
So of course, we're talking to you in the context of a lot of conversation and effort in the other Washington to pass the president's priority legislation around the budget and ongoing spending, and contained in that are significant changes to the Medicaid program, as well as to the way that Obamacare, the ACA, works. So as you are looking at what's being proposed, what's passed the U.S. House, what's being considered in the U.S. Senate now, big picture, and then we can kind of break it down. Mm-hmm. What are you seeing? What has you concerned?
Some people, Austin, are calling this repeal but no replace. So the two pillars of the Affordable Care Act that you just mentioned were the Medicaid expansion, as well as establishing the marketplaces for such as state-based exchanges such as ourselves. So this bill has major provisions which would create savings by reducing coverage in both programs in order to extend and fund tax cuts. So that the global number is 16 million people are projected to lose coverage, and that's Congressional Budget Office analysis of the House-passed reconciliation bill known as the One Big Beautiful Bill Act. And that's about half of those losses would be individuals who would lose their Medicaid coverage, and half would lose in the marketplace. So some of just highlight of like the gist of the provisions that would be the mechanism for those losses. On the Medicaid side, it's work requirements. So we know from state innovation in other places, they don't actually move people to get back to work or go to work, but they do create a lot of administrative hurdle, and it's estimated that 138,000 of our folks on Medicaid would lose coverage due to that provision.
That's just here in Washington State.
That's here in Washington.
And again, that's a proposal that Republicans in Congress have said, look, if you're going to be on Medicaid, you got to be working, unless you are permanently disabled. And so,
Correct.
and you'll have to prove as much. And what you're saying is, rather than a bunch of people who are not working today and on Medicaid going back to work, it might actually
Right. We know that the majority
provide an
of
exit
people on Washington Apple Health are working, or they're a caregiver to a relative, or they have a disability. So the intent of the policy, that the impact of the policy will be just to reduce the caseload, reduce the rolls.
Before we kind of keep going into details about the changes that are being proposed, this is all under, or a lot of it is under the auspices of rooting out waste, fraud, and abuse in Medicaid, as you said, looking for cost savings. There's a lot of people out there who are going to say a program like Medicaid has got to have a lot of waste. And people who are benefiting maybe should have more skin in the game, paying some co-pays or co-premiums, I guess they would be, having to work. So what Republicans are advancing and sort of the reasons they're giving, respond to some of those
Sure.
ideas.
I mean, just compare. So you go through an eligibility process to be qualified for the Medicaid program. You have to be very low income. When you have employer-based insurance, you don't have to prove every month that you're still, eligible. You don't have to. You automatically renew. So this creates really cumbersome levels of paperwork and administrative hurdle. And what we know from research is the more hurdles people have to getting what they need, the more who will drop off. So it very intentionally will have the impact, and there's no studies that show that it is effective in getting people to work who are currently not working.
What about, let's use the co-premium example, which I think was it $35 a month?
Yeah, and Austin, I want to acknowledge that the Healthcare Authority runs the Medicaid program, Washington Apple Health. So I don't want to speak in too much detail to the Medicaid provisions. What we are experiencing at the exchange is being the front door and helping with that eligibility process. But you're absolutely right. It also calls for co-pays for folks on Medicaid.
So the changes that are being contemplated have implications both for Medicaid and for the health benefit exchanges. One of the other things in consideration is that states that provide care to people who are undocumented, if they continue to do so, will lose some of their Medicaid share. And again, I understand you're not the Medicaid director, but can you just speak to the 10% penalty, if you will, in a state that is providing through state funds,
Right.
not federal funds, but state funds, this sort of care? And that's been maxed out.
It's a
I mean,
provision.
There's a high interest in that program.
Yeah, so it is a provision in the House passed bill to have a 10% penalty on the federal match for the expansion population if a state is using their own dollars for coverage programs, for health coverage programs for people who are undocumented. So there's a lot of questions around that. State autonomy comes into play, state flexibility. We've made a decision to advance equity in our state by ensuring that people who are undocumented also have access to the Medicaid program and to purchasing coverage through the exchange.
Okay.
So that we'll be watching and taking guidance from the governor, from the legislature, on what to do with current programs if that remains in the final package.
Okay, so we've highlighted some of the changes that are being contemplated for Medicaid, but you just said half or more than half of the people who are projected, the 16 million who are projected to lose coverage if these changes go into effect, are going to be on the individual market side. So how do we get there? Because I thought the changes were all going to, for the most part, affect people on Medicaid.
Yeah, I really appreciate you asking because I think it's falling a bit under the radar. But it is, some people are calling it, death by 1,000 cuts to our state-based exchanges. It's a number of small and some very large technical changes that will make it harder for people to get enrolled and to stay enrolled in private health insurance and to get the support and assistance they need to make it affordable. So a big one is the enhanced premium tax credit. So we have always had a baseline of tax credits, like we have for a lot of other things, is embedded in the Affordable Care Act.
People can think of these as subsidies to help bring down your
Yeah,
premium?
it's just like a child tax credit. There's many tax credits that we as taxpayers are eligible for. So that has been enhanced for a period of time.
During COVID.
Started during COVID and is scheduled to expire at the end of this calendar year. So it is not in the bill to continue that enhanced level of tax credit, even though it's been very robust in increasing the number of Americans covered. So there were efforts to include it in the bill. It's not in the bill. It's a possibility that Congress could also address that
Separately.
later in the year, before the end of the fiscal year in the budget bills. But that provision alone, I mean, just taking it down to the Washington state level, our actuaries have predicted that 80,000 Washingtonians, 80,000 out of our 300,000, would make the difficult decision to drop coverage if they no longer have the level of enhanced tax credit.
And remind
So
us
it's
what
very
those
threatened.
enhanced tax credits look like for people. How
It
much?
is different for every individual based on their income, their family size, and other variables. So there's not one set number, but it's a huge driver of affordability. And depending on individual circumstance, their rates could be 50, 75%, or 100% higher if the enhancement is allowed to expire. So it's a huge risk for our state. And that is a major driver, but it's not the only one.
So what else is sort of under consideration that could affect the individual market?
So the Center for Medicare and Medicaid Services, CMS, proposed regulatory measure that is also proposed to be codified in the reconciliation package. That's sort of technical language, but let me explain some examples of the cuts to marketplaces that are in there. So one is just shortening open enrollment. So currently it's November 1st to January 15th.
Or 2 months.
Yeah,
or
it's
2.5
90
months.
days.
Yeah.
So they would shorten it. So they, instead of states having autonomy for how they went, what their open enrollment periods would be, it would be clipped.
To what?
To 45 days. So November 1st to December 15th. The problem in our state is about half of our new enrollees last open enrollment came in at the tail end there between December 15th and January 15th. And our data shows that they were some of the youngest, and on average, they're younger and healthier. So you got to think about risk pool, because it's not a big market, but it's an important market, because people who no longer have health insurance through their job, they're waiting to get on Medicare, like the bridge to Medicare folks rely heavily on our market. Nearly a quarter of our market are self-employed and small business folks. So it's a small market, but important for people who otherwise fell through the cracks of the system and were uninsured. So if it gets smaller, then the risk pool will cause everyone's prices to go up.
But why would you not just presume that those were the procrastinators? They knew they had until January 15th, and now if they have until December 15th, they might still wait, but they'll do it in the first 2 weeks of December.
Austin, this is just one of many, many measures in the administrative rule and now in the bill that is going to make it more difficult and more paperwork and more delays and just create all kinds of barriers in the system that will make it harder for people to sign up and get enrolled.
What is the argument that has been made for shortening the open enrollment window?
I am really not sure, because I know that this administration is sensitive and understands the risk pool problem and is very concerned about the unsubsidized customers. So a large portion of our customers are unsubsidized or no tax credit, and they're buying in this market, and this will hurt them as well. So we're not really clear of the motivation, but shortening open enrollment, creating more restrictions around what we call special enrollment periods. So if your income changes and now you are eligible, allowing you to get in outside of open enrollment, it's a lot of small but significant changes that create sludge that make it hard to get in, and people who need our coverage the most will tolerate it and still come in and shop and compare, and we want them to do that. But younger, healthier folks might just say, "Oh, forget it. I can't bother with this," and not come in. And we need them. We need a robust market to make it affordable for everyone.
And I know that the state has been working to try to create a more stable and widely available individualized market, make sure that there's more than one option in all 39 counties, try to get control of the double-digit increases in premiums that we've seen in some years. And just brings stability to that. So when you look at the proposed changes in Congress, to what extent do you think that could undermine the long-term viability of this exchange?
We're concerned, and we're also strong and resilient, and we're keeping our doors open. So we are now serving 300,000 people. I'm worried that our market will reduce by a third or half on the individual market exchange ACA plans. That will be a real hardship for everyone who is pushed out, who can no longer afford, or who's no longer eligible, either to shop in our market at all or to receive premium tax credits.
It would also raise the number of uninsured in this state.
It would. So we will be heading back into double digits. If you combine the projected losses on the exchange side, so say 100,000 would be a third, and then on the Medicaid side, somewhere between 200 and the initial estimates were up to 500, that will have a big impact, not only on moving us back into double digits of uninsured, but on the whole system. Because people who, if we had that level of uninsured, the hospitals, the clinics will really feel the pressure, the pinch, increased demand for charity care. The state government, the state fiscal crisis will be exacerbated with a huge loss of federal funds.
What do you think if there were 100,000 people who left the individual marketplace, what would it do to that marketplace and the offerings that companies are now offering?
It will increase prices for everyone in our market, and then more globally, the combined coverage loss across the Medicaid to marketplace continuum will increase prices for everyone, including commercially uninsured.
We're already seeing perhaps a harbinger of the impacts because the insurers needed to submit their proposed rate increases for the next round here, and they're seeking an average of 21.2% in increases. And a big driver of that is the pending expiration of the enhanced advanced premium tax credits. Obviously, the insurance commissioner is going to review these and doesn't have to agree to that. But it does seem as though that the industry is seeing some clouds on the horizon. So how are you kind of filtering and thinking about and interpreting that? Because that's a big spike.
Yeah, it's a very concerning signal, and it is really a symptom of the major uncertainty for our healthcare system overall, not just our Medicaid and marketplace coverage. So we're unpacking that. We know part of it, those rates so process-wise, just know this is the initial proposed rates. It's the beginning of a conversation. The actuaries at the Office of the Insurance Commissioner are doing deep analysis. My team has just recently received that data, and we're also doing our analysis. Part of it is just utilization and price. Those are the main assumptions. We continue to struggle with healthcare cost inflation in our state. We're making some progress, but not enough. So year after year, we've had 10% rate increases the last 3 years, and that's been a major driver. We can see from what they filed, based on what the insurance commissioner requested, that the expiration of the enhanced premium tax credit accounts for 6.4% of that proposed average gross premium rate increase. So that's a chunk of it.
But it's not the majority of it.
No, so it's 10% is sort of shouldn't be our new normal, but that's what we have seen.
That's kind of what they're saying.
Yeah.
Healthcare costs are rising.
Yeah, and we haven't addressed that enough. And then 6% on top of that.
It's losing the premiums.
Yes. And then there's the uncertainty. And in response to that uncertainty, we appreciate that the insurance commissioner worked with us on a mitigation strategy to draw down federal funds that will be lost with the enhanced premium tax credit expires. And it's a complex proposal called her emergency rule around standardized silver loading. And what that's doing is the price of the silver plan looks much higher, but setting that benchmark higher enables us to draw down a lot more federal funds. So if you look at the bronze and gold plans and you look at the data in more detail, the average price increase, proposed premium increase on gold and bronze is just 7%. So there's a lot going on behind that number that you see, and there's going to be a lot more conversation until there's final proposed rates, or final rates, excuse me.
Going back to the subsidies, your exchange has estimated if the enhanced subsidies go away, 80,000 people could roll off of the individualized marketplace. A minute ago, you were talking about potentially a third, and we were using the 100,000 number. Would that be another 80,000, or are they included when you talk about
So
100,000?
that 80,000 is like the base of what we're worried about because it is very likely that that will expire. I think there's a slim chance they'll revisit it. But then on top of that, there's
other
all
changes
the
that they're-
provisions. And I said like death by 1,000 cuts. It's a
that
lot
could
of
add on top
yeah,
of that.
that adds on top
But
of
the
80,000.
bulk of the people that would leave would be because they lost the enhanced subsidies.
Because the prices go up
right.
so much for everyone when that happens. But I don't want to underestimate the process changes that we will be asked to do will cause significant premium loss, or excuse me, enrollment losses. So when people can't come, there's only a short time you can come in, or you can't come in under special circumstances. And then instead of us, we have great technology. We ping what's called the federal hub. People can have an in real time eligibility experience, shop for a plan, sign up, and get enrolled. The kind of paperwork burden, administrative burden.
What's an example of the paperwork?
So they what we do is we do an
And
automatic
again, we're on the
ping,
individualized side.
right? And if there's a discrepancy between what the customer said and the ping, we put them in a conditional status and we reconcile and verify, and then they're
Because you want to make sure they're
Yeah,
eligible
yeah.
for
So-
insurance and for the subsidies they
so
might be.
we already have
getting.
robust systems in place to ensure that people are eligible for the premium tax credit or for Washington Apple Health. What they're saying is you have to have the customer submit their documentation in every single case. So starting in year 28, it would like move us back in time a decade or two in how efficient and we are in use of good technology, and require it and slow down the process. It cause us to employ people to just review paperwork. It just makes no sense.
And you don't think that second check is needed to verify
No, we already
eligibility?
double check anyone who we see a difference between what they're telling us and what Social Security Administration, Department of Health, Homeland Security, all these trusted federal sources are saying. So we already have the robust verification in place. The big killer, Austin, is this would make it very difficult for us to do auto renewals. So when people once they're enrolled, we make it easy and fast to re-enroll in the same plan that you had this year for the next year. This would require us to get back to you, have you submit all your paperwork again in the slow, low-tech process. So it's very concerning, and it won't just impact some of our customers, it will impact all of our customers.
There are other perspectives about kind of what's looming and pending here from the other Washington. I asked Senate Minority Leader John Braun recently specifically about the Medicaid cuts. It wasn't as much about the exchange, but let's listen to what he said, and I'd just be interested to sort of get your reaction because he had a slightly different, or perhaps a significantly different perspective about this. Here's what he said a couple weeks ago.
I think there's a lot of fear mongering out there. I think that in many ways, what passed the U.S. House is much more favorable for Washington than what many people thought. There is a reduction from 90% match to 80% for states that have basically Medicaid for undocumented workers, which Washington does. That's going to be hurt, but also put some reforms in that we've championed for a long time, making sure able-bodied folks are working, making sure that we're verifying folks are eligible if they're getting those services, making sure that we don't have folks cross-enrolled between different states. These are things that will not only save the federal government money, they'll save the state government money and allow us to deliver services more equitably to the people that really need it.
And part of his point there, and again, I acknowledge that you're not the Medicaid director, but it is a split program, 50-50 state and federal dollars. So he's saying it'll save the state money as well because state dollars are on the line when it comes to Medicaid. But that perspective that, hey, this may not be as bad as it sounds, and there may be some upside advantages.
Appreciate Senator Braun's perspective and wish I could agree with him. But what we are facing is a massive loss of federal dollars coming to Washington State on top of a state fiscal crisis. So on the marketplace side, it's $275 million less in tax credits that people will be able to use their own money plus the tax credit to purchase private health insurance.
Give us that number again.
$275 million.
In
Right.
subsidies that if they're not renewed, go away.
Right. So the folks who are most benefiting from tax credits are in the rural areas of our state by far benefiting from that, as well as Cascade Care Savings, our state premium assistance program, which we were very grateful to the legislature for approving and funding at least for one more year, even in this tough fiscal space. The two together are very powerful in helping small business owners, gig workers, self-employed people, young invincibles, people on the bridge to Medicare. So these are the kind of folks, and the KFF did a poll that came out today that showed that a marketplace coverage, which is exchange coverage nationwide, 45% of the folks who benefit from that coverage are Republicans. Overwhelmingly, the red and rural states and Republican states will be harmed the most, and our state will be harmed. So in a situation where people not having coverage, what does it do? It's like people still get health care, go and access health care anyway, and that hurts our hospitals with charity care burden. People are going to have to wait longer in the hospital because the hospitals and the clinics will be pressed. They'll go into medical debt. They won't be able to pay other bills. This is not good for our state economy, and it really puts pressure on the state budget because those folks will be leaning into the state for all matter of other services, and the state will have to work with the healthcare system to keep it afloat. So losing federal Medicaid dollars and losing $275 million in federal tax credits coming to our state, I'd say that's not good for our state fiscal situation.
In 30 seconds, we also just came through a tough budget year in this state. What would you say about sort of the state of Medicaid and the insurance, the exchange today, even before these cuts?
Yeah. We really appreciate, the legislature's support for Cascade Care Savings. Our general fund, there's a very small level of general fund that comes to help people with that premium assistance.
And that's
Primarily,
the state plan?
Yeah, no, that's the Cascade Care Savings is state premium assistance.
Got it, okay.
Yeah, but the exchange plans are self-funded through premium tax and carrier assessment. So we don't lean heavily we don't rely heavily on the state budget, and the Medicaid program is heavily funded by the federal government. So the state benefits greatly from both. So the weaker these two things are, the more stress on our state budget and harming real people, and that's the real issue.
Okay, I'm going to stop you there. Ingrid, Ulrey from the State Benefit Exchange. Thanks so much for coming.
Yes,
Appreciate
thank
it.
you, Austin.
When we return, an update on the status of Washington's long-term care program. Back right after this.
There's been losses every year since the early 1920s. The shoreline itself was almost 2 miles further out there. Year after year, more homes would fall in the water. We have nothing to lose.
And welcome back to Inside Olympia. In 2019, majority Democrats in the Washington legislature passed a law to create a first-in-the-nation long-term care benefit program paid for by a mandatory payroll deduction or premium. In 2023, payroll premium deductions began with benefits scheduled to start next year. Last year, conservative activists ran a ballot measure to make participation in the program voluntary. That failed. So what is the status of the program? What changes have been made, and how is the state responding to ongoing opposition from some to the program? Joining me now is Ben Veghte, director of the WA Cares program. Welcome back to the program. Nice to see you.
Great to be here.
Looking forward to a little catch-up on this program. So, we go back several years to its origins, but now you're almost ready to really launch this thing. So for a moment, let's just transport ourselves into 2026. People are already paying the premiums, but what happens in 2020? When does this happen, and what will happen in 2026?
Sure. So we're going to run an initial pilot in spring to test out our systems, but the program goes fully live in July of 2026. And people who have been paying into the program for the past few years, if they have a long-term care need right away at program launch and they've paid into the program, they could be eligible for benefits in July of 2026. So we expect about 38,000 people to claim benefits in the first year of the program.
How would this work if the mandatory or the maximum benefit is about $36,500? That gets adjusted for inflation. But if you've only been paying in for a couple of years, and let's say you need it,
Right.
and you're one of those first people who needs it.
Sure. Well, there's three ways people can qualify for benefits under the program. One is by paying in 10 years over a career. That's the way most of us will qualify over the long term. But then there's also two other pathways. So, for example, for near retirees, people born before 1968 who are older than about 55 today, they would earn 10% of the full benefit for every year they pay in. So even if they've only paid in a couple of years, they would be eligible for a partial benefit if they needed care right away in 2026. And then there's a third category, which is designed for people who have an illness or accident in the course of their working lives. You might be 35 years old and have a motorcycle accident or a ski accident or get cancer and get laid up and need long-term care for a period of time. Those people could also, they can access the full benefit as long as they've paid in 3 out of the past 6 years at the time they're applying for benefits. So in that first year, we expect some of those people to be eligible.
How would that category of people be eligible if we've only been paying since when?
Well, it's 2023, so it's been 3 full years.
So it will have been 3 full years.
That's
So
correct.
so at that point, and what's the trigger again for eligibility?
If you've paid in 3 out of the past 6 years at the time you're applying, you're eligible for the full benefit. For people
Who have an event like that.
Correct.
Got it. So moving backwards in time then, and we'll note that this is being funded by a payroll premium, comes out of people's paychecks.
Correct.
The employer's not paying a percentage, it's all borne by the employee.
That's correct.
It's 0.58%, that's the percentage of the premium. What is the average Washingtonian paying per year out of pocket for this? How do you think
About
about that?
$290 for the median covered worker.
$290, roughly $300 a year. And that also, does the premium change over
No.
time?
Premium is locked at 0.58%, a little over 0.5% of people's wages. And we have actuaries who look at our program's finances over 75 years. They've determined that premium rate, the premium rate is set in law, and based on that premium rate, they set the benefit at 36.5, and the premium rate is not projected to go up over time.
You mentioned what the actuary is estimating, or you guys are estimating in terms of how many people might avail themselves in year one, essentially, of this. What do the out years, say 3-5 years out, look like?
Sure. So in the first year, we expect some pent-up demand from working age people with disabilities. So many people use long-term care in order to work. If you have multiple sclerosis, for example, you might be able to work really productively in a job, but maybe you need help getting ready for work in the morning. And so some people will use it. Have been paying in the last few years and qualified for benefits. And so we have those people who are in the workforce now who might apply right away for their benefits. But then in year 2, we expect the claiming to drop significantly to about a third of that, because then that pent-up demand will have been met, and you'll get more aging-related long-term care as the main type of claiming. And so those near retirees will slowly start to claim, and numbers will go up over time. And then 10 years out, you'll get the way most people qualify by paying in 10 years over a career, and then you'll see a lot more people claiming at that point.
And remind us of how you can use this benefit, what it can buy.
So it's for any kind of long-term care that the state contracts for. We have 19 different types of services and supports that people can use it for. So you might want to bring a professional home care aide into your home. That's something that most people will want to do. Either bring in a professional, or you can make a family member who's caring for you a paid caregiver if they so desire, and pay them to care for you. That's probably the main way people are going to use it. The vast majority of people, according to AARP, want to stay in their own home as they age. People don't choose to go to a nursing home unless they really need to. So for most people, this is going to be a home care benefit. But you could also use it for meal delivery. Let's say my mom lives an hour away from me, and I look in on her periodically, but I can't be there all the time. But I don't feel like it's safe if she's cooking anymore, because I might start a fire, or I don't want her going in and out of the kitchen and maybe falling. I could have meals delivered to her home, and then maybe a few hours of home care a week to help her with bathing and dressing, things like that. So you can use it for a mixture of things like that.
I know I've asked you before about the 36.5 kind of lifetime benefit and how quickly that could go if somebody needs ongoing care, and the fact that everybody qualifies for that, whether they'll need it or not, as opposed to if somebody needs more care, they could get more. If somebody never needs it, then their portion could go to others. Why is it structured like this? How useful or effective do we think a benefit of that amount will be?
Well, about a third of people need long-term care for a year or less. A lot of people just need it for the last 6 months of their lives. And it would allow someone to spend, that last year of their life in their own home before they pass away, rather than having to go to a nursing home, which really is no one's plan for the last year of their life, right? So that can bring a lot of benefit. For other, really, I see this benefit as providing resources to families to cope with a really difficult situation. So let's say, my mom needs care. Maybe she ends up needing $50,000 of care. Maybe the family can use that benefit for most of her care, and the kids can kick in the rest, or provide in-kind support if we can't afford it out of pocket. So there's lots of different ways that the family can leverage the benefit. And the other thing worth highlighting is that this year the legislature enacted the statutory framework for a supplemental private long-term care insurance market that takes walk cares as the deductible and lets carriers offer coverage on top of that. So if I want to buy an extra 50, 100, 150,000 of coverage on top of walk cares, I could buy that at a more affordable rate than I would today or previously, because walk cares covers the most expensive part of the cost for an insurer, which is the first tranche of risk. They should be able to market these policies at lower price points than they do today.
Interesting. Well, that's a nice segue to talk about, and we've talked about the future of this program. We'll sort of back up in terms of chronology here and talk about what happened in the 2025
Sure.
legislative session to make some adjustments to this program. You've just addressed one. What is your confidence level, and what are you hearing from the private market about responding kind of to this change in the law with more private options?
They're excited about it. We developed this model collaboratively with private insurers. So starting in 2022, we started working with 5 insurance carriers, as well as consumer protection advocates, to the Long-Term Services and Supports Trust Commission, which is our oversight body, formed a work group that had carriers on it, had consumer protection folks on it. They made a recommendation to the commission, which then recommended it to the legislature, which became this law. So 5 carriers have signed off on the law as being feasible, and 2 carriers have expressed strong interest in entering the market as soon as it goes live, which is probably January of 2027. There's about a year of rule writing that has to take place, and then carriers can file their policies. But I know that carriers are planning on entering this market.
And I know that there has been, from advocates of this program all along, a feeling, a belief that by having a public option, a public benefit, it could actually serve to augment the private marketplace, and then those two could work together. Help me understand a little bit more in detail how this would actually work in practice, though. Let's say a person does want to go out and buy private long-term care insurance. It's very expensive right now. It's not even always available. I think initially that the market sort of shut down when people were trying to buy private insurance and opt out of this program. How would it work? How much would a person be potentially paying out of pocket to get that additional benefit?
Sure. Well, we expect the carriers, currently it's about $3,000 a year for a standalone private long-term care insurance policy on average nationwide. We expect carriers to enter this market and to market these policies that the carriers are interested in expanding into what they call the middle market, the middle class consumers. Mm-hmm. Right now, the private long-term care insurance industry as a whole is really restricted mostly to very high earners or kind of workplace policies that many people don't keep after they change jobs. And so they see this as an opportunity to sell to policemen and policewomen, firefighters, teachers, average middle-class consumers across our state. And to do so, they're willing to offer coverage at more affordable price points. It might start as low as $50,000 of coverage, which could have a premium that's much lower than that $3,000 figure I mentioned. And because they would have much larger volume of sales, there's a certain economies of scale, which could also lead to these being sold at lower price points. And if the model in Washington State is successful, they could then scale that across the country, and it creates a whole new market for the private long-term care insurance industry.
And again, the first insurance you would use would be the public insurance, and then they would be the backup.
Correct.
After you run through the 36.5.
Correct.
Let's talk about some of the other changes the legislature made, including, and I referenced this, that when this was being set up, there was a one-time opportunity for people to opt out if they could show that they had purchased private insurance on the private market. And now, as I understand it, the new law allows people who maybe have some, I don't know if it would be buyer's remorse, maybe it's remorse about having exempted themselves.
Fear
from the
of missing
program.
out, right?
Fear of missing out. Get back in. So
Yes.
what prompted that change? What are you hearing from people who got out and now seem to potentially want to get back in?
Sure. Well, we were the first state in the country to do this. So there were some issues in our original statute that need to be ironed out, which is why in 2022, the legislature put a pause in the program, gave the legislature time to implement some recommendations that the commission had made. And two of the key improvements to the program since then are the near retiree pathway. Previously, people close to retirement might have paid in and not been able to benefit.
Because they couldn't get the 10 years.
Correct. And so the legislature fixed that. The other big one was portability. You might have retired and moved to Arizona to be near the grandkids and never been able to use your benefit. Right. Now that those two things are fixed, a lot of people who opted out in 2021 feel like, now this is a really good value proposition for me. And they have now until 2028 to join the program if they so desire. And we hope that many of them come back. We've heard from about 6,000 people who've contacted our customer care center expressing an interest in coming back.
So that will now be an option.
Yes.
Whereas before it wasn't.
Correct.
What other changes were made in the 2025 bill to this program? You referenced earlier changes that were pretty significant, but what other changes for this year?
This year, the other changes are mostly minor technical fixes. One of the ones was that initially you had to pay in 10 years without a 5 or more year interruption in your career. That language about a 5 or more year interruption was removed. So as long as you pay in 10 years over your whole career, it could be 3 years at one point. Maybe you take 7 years off to raise kids and go back into the workforce and work 7 more years. You would still earn those 10 years. It doesn't matter when you work during your career, as long as you accumulate 10 years, you satisfy that threshold.
You mentioned that this was a first in the nation program. What is it catching on elsewhere? Have you seen legislation introduced that mimics this or is based on the Washington model in other states?
Absolutely. In fact, many states are envious of how far ahead we are. I just did a webinar today with the state of Massachusetts where they said they're 10 years behind us, and they were disappointed in that because they were the first on the Obamacare. Romney Care was the predecessor of Obamacare, right? Mm-hmm. And so they saw themselves as pioneers, but we actually started discussions in 2014 about WACARES. About 10 other states have introduced legislation. No one has enacted it yet, but there are coalitions in several states, California, Massachusetts, New York, Minnesota has looked at this, and there's many other states, Hawaii, who are interested in doing something similar. And I think 10 years from now, you're going to probably see 3 other states at least that have programs similar to WACARES.
There are, of course, still detractors, and there was this effort in 2024 to make it a purely optional program, which obviously would have financial and actuarial implications for the program. Interestingly, voters rejected that by pretty wide margins and in a pretty geographically diverse fashion. Let's start with, what was your takeaway from that vote?
Simply that Washingtonians realize that the vast majority of us are not prepared for retirement, much less for this added big expense that could hit us in retirement. 7 in 10 of us are going to need long-term care. Most of us don't have a way to pay for it. The average household income of retirees in our state is $56,000. 83% of workers approaching retirement have no pension and or less than retirement savings that are sufficient to replace less than 10% of their pre-retirement income. So only 17% of Washingtonians have retirement savings that are able to replace more than 10% of their pre-retirement income, which means they're living on Social Security plus whatever they can earn. And so most people end up running out of money in their 70s, and certainly by their 80s they run out of money. And so that's to have a long-term care need at that age really is a tough thing to hit a family. It means the kids have to pay for it, or someone has to quit their job to care for mom or dad. Older adults don't want to be burdens on their children. And so it's just it's a need that people have. And if the program were voluntary, the program would probably have to be repealed altogether because it would be actuarially unsustainable. And I think people just wanted to keep the program.
It's interesting that given how much of that election, the 2024 election, at least nationally, seemed to be based on pocketbook issues, people concerned about rising costs across the board and inflation, and this is taking a bite out of people's paychecks that nonetheless they voted
Absolutely.
to. And, without surveying a bunch of voters, we won't truly know what was in their mind as they voted on this. But it is worth noting that in kind of an economically tense time, voters still upheld this program.
Absolutely. And I think part of it may be that people realize that even though the premium is an expense, if you don't have the program, then you're paying for it at a far more vulnerable time when you are in your 70s or 80s and can't work because you have a disability. And you could also see it from the perspective that today we have an implicit tax on family caregivers, right? When family caregivers have to bear the entire burden for all of our families. And I'm sure it's no different in your family than my family, that there's always like one or two people who are the kind souls who end up doing the family caregiving at the cost of their own financial security. Oftentimes a woman does this for maybe her parents and or her spouse's parents. Maybe they get divorced later. She retires one day and has virtually no retirement savings because she was doing all this herself. So this distributes, WalkCares distributes the privilege and the burden of caregiving across all of us, and gives families more choices.
Do we think that there's a sufficient workforce to do this work?
Well, that's an interesting question. It's a challenge that we're very focused on at DSHS, where we're working on recruiting more people across the state, more young people to go into this field. But we also expect that with the increase, so if we look at other countries, for example, that have similar programs, in Germany, they enacted a program like this in 1994. And in the 20 years after that, they saw a tripling of the number of providers of long-term care in their country. We expect that in a lot of rural areas where younger people tend to leave and the older adults are often the ones who remain, and there aren't that many jobs for young people, and that's why the people leave. Then now that older adults are going to have money to spend on long-term care, you might see more kids staying in those communities, starting home care businesses, meal delivery businesses, and other, you have 19 services and supports, building ramps, grab bars, because there will be money to spend to help support those communities. So it could actually cultivate jobs in a lot of areas.
So we've established that this initiative failed. But there are still those who will argue, and have argued, that the program's mandatory nature infringes on individual choice. That people don't have the option to be in or out of this program, and say, vote, the public should have the option. And State Representative Jim Walsh, at the time that this initiative was before voters, said that it simply lets people opt out if they choose. It defends consumer choice and encourages transparency in state programs. What's your response to those who believe, maybe they voted for that initiative, that a voluntary model would better respect individual autonomy?
Sure. I mean, these questions are up to voters to decide, right? The voters in the legislature to decide. You could either have a program like this or not have it. But I think it's important to know that there's no middle ground. You can't have a voluntary program. There's no such thing as a voluntary public long-term care insurance program. It doesn't exist anywhere in the world. Social Security and Medicare are not voluntary. Unemployment insurance is not voluntary. So if Medicare were voluntary, it would become insolvent in a few years. You end up with a high-risk pool where low earners who are, sick low earners are in and healthy high earners are out. And also, like, even people like myself, I'm a middle class, upper middle class person. I need this program as well. When I get older, I don't have enough money saved for retirement, my wife and I, to feel comfortable throughout our retirement, even if we have a long-term care need. It's not just a program for low-income people, it's a program for everyone. And I know, I look at my father, who is kind of a rugged individual who thought he would never need long-term care insurance or support, and he'll tough it out if he needed it. But he fell down the stairs in his cabin in the woods when he was 83 years old, and guess what? He needed long-term care. Mm-hmm. And so, and it's not he himself who has to bear the burden of that. It's the kids who help out. So it's important to remember that these are not individual choices. We don't exist as individuals. We exist in families. And if we don't prepare ourselves for this need, our families are going to be the ones who suffer the consequences.
If I'm not mistaken, you've described this as a social insurance program.
Correct.
So, and the way the very nature of a social insurance program is everybody pays in. It's not optional.
They're always mandatory. Yeah.
There has also been some concern, and obviously, you said it wouldn't be sustainable if it was optional, but there has also been some talk about its long-term viability from a financial standpoint. If you go way out in terms of the actuarial tables. What does the modeling show? How sustainable is this? What are the potential risks to its solvency?
The program is extremely strong actuarially. So we have the state actuary and external actuaries as well monitor our finances every year. They report to the commission, which oversees us, and the commission reports to the legislature. We are projected as solvent through the end of the century, which is the entire 75-year window that they look at. And every year, they look at our finances, and make sure that we're staying solvent over the 75-year time frame. We are different from Social Security or Medicare in that we have our program was recently enacted. Those programs were enacted a long time ago. So we have already priced in the boomers' retirement, the age wave, into our projections. We've priced in longevity increases that have occurred, and so and increased dementia prevalence that exists today. So all of those factors are priced in. If something were to change in the future unexpectedly to increase our costs, the commission and the legislature would fine-tune the program to make sure that we stay solvent over the 75-year frame. They are obliged by statute to pay, the commission is to maintain our solvency over the long term, and so that's just a process that is at the front of mind for everyone involved.
Remind me, are the premiums that are collected, is there flexibility in what happens to them? Can they be invested?
Yes. So good question. The money that we need for immediate expenses, administrative expenses, and then starting next year benefit expenses, we keep in the agencies to spend on benefits. The money that we don't need, if we have excess money that comes in, which we will over the first couple decades of the program, that money we send to the State Investment Board, which is the entity that manages the state pension plan and many other state programs. They are the best in the country at managing public investments. Many of the people from some of the top companies in Seattle are on helping make those financial decisions. And so they invest in a mix of, right now it's everything except equities. I know this year there's a ballot initiative that the legislature put on the ballot, which would give the State Investment Board also the opportunity to invest in a more diversified portfolio that includes equities as well. But currently they invest.
So that has to go to voters.
That goes to voters in November. But
And
currently.
to expand the investment options for this particular fund?
Correct. Because that already exists for many other programs.
And to remind me, is this something that voters has gone before voters before and they rejected?
In 2020, the COVID year, I believe it was rejected.
So this is sort of a second attempt. Okay.
Correct.
And okay, so go ahead.
Yeah, so currently, the State Investment Board invests in a range of investments, corporate bonds, treasury bonds, other fixed income investments, to earn investment income that'll help pay the benefits over the long term.
But there's a restriction now on investing in equities, which could potentially generate larger returns.
Yeah.
When you look at the actuarial projections, how important is it to the long-term viability and sustainability of this program and solvency to be able to have that additional investment option?
I can't speak to that because that's before the voters.
Got it. So I want to ask you about another criticism that comes up from time to time, which is, again, going back to this payroll premium. I know you don't like the term tax, payroll premium. Some people call it a tax, but it's viewed by some as regressive, that it's disproportionately impacting lower income workers because it's a flat amount. And so as a percentage, a lower income worker who's making less money is going to pay more as a percentage of their income compared to higher earners. Opponents have called it a regressive tax, and we know Democrats who have championed this program are always talking about progressive taxes. How do you address that one? How do you reconcile sort of the equity piece?
That's a great question. And WellCares is not a progressive or a regressive program. It's a long-term care program designed to help us all contribute while we're working so that we're protected against the risk when we experience the risk, just like all social insurance programs like Social Security, Medicare. So one thing to keep, it's true that the contribution rate is flat, just like for Social Security or Medicare. It's also true that lower income people are more likely to need long-term care than higher income people because health status correlates with income and lifetime earnings. And so it all balances out over the long term. And so I think overall it's neither regressive nor progressive. It's
just in the minute we have left, what do you see? You talked about what comes next year in terms of the benefits starting to pay and be available, but what additional enhancements, changes do you think will be considered in the next couple of years, whether that be legislatively, by the oversight board, or both?
The program is set to go. There have been a lot of improvements made over the last 5 years by the legislature in response to recommendations by the commission, which oversees our program. We have a constant feedback loop with the public where we do community meetings with people all across the state. We get their ideas. We share those ideas with the commission, and the commission also brings its own ideas. So there is an open door for any new ideas that Washingtonians have for improving the program. But right now, I don't see any weaknesses of the program. I think it's all the problems that were originally there have been fixed, and the program is good to go. Of course, as we gather experience serving the public and delivering benefits to people, we will continue to fine-tune the program based on the experience that people have with the program.
And just lastly, how excited are you about 2026?
I'm tremendously excited. Both my parents have needed long-term care. I've seen how vulnerable people are in that situation where they are unable to live independently. Sometimes people go to a nursing home and they lose their clothes after a few months, and they're often stuck in a bed and waiting for a nurse to come by. Most of us want to age in our own homes, and Walk Cares is going to allow more people to spend the last couple of years of their life in their own home, surrounded by family, and I'm really excited about that.
Okay, Ben Veghte, Director of Walk Cares, thank you for coming in. Appreciate the update.
Thank you, Austin.
We'll keep in touch. And thank you for watching Inside Olympia. We'll see you again next week.